kind of like your ketchup bottle analogy. I always tell families that are having a hard time understanding, I said, you know, it's kind of like having a car sitting here idling. They're kind of on idle right now. I said, yes, they're going to use up some of that gas, but you can't just put the gas pump in there and leave it running because it will spill over. And you know, that's the same thing that happens with hospice patients. If you try to, or anybody at end of life, I know all of us have taken care of patients that are so bloated. You know, they've just got generalized edema, weeping, and it's because they're so fluid overloaded. And people used to, you know, always say, well, does that not break your heart to do hospice? But I will tell you, what breaks my heart worse is to see people come straight from the hospital and lay there and drown because they have so much fluid in their lungs. And I worked in the ICU, and I worked on med-surg, and I do think that there are times it's wonderful and it's definitely needed, but you know, I think we need to help people be educated so that they can choose to make decisions based on education and not TV, you know, decisions. So, as people decline, their bodies quit wanting food, and they even will quit swallowing. You know, your mouth is all part of your GI tract, so they'll quit swallowing the food even. You know, I told families, you know, for thousands and thousands of years, that's the way we died. We didn't put IV tubes in people, or tube feeding and IVs and give them stuff like that, and they died okay. You know, so it's just normal. You know, people at a baby need something different than a 16-year-old needs, something different than a 50-year-old needs, and something different than death. Yes, ma'am.
When a patient is in that dehydration mode where they don't need or want food, fluids anymore, a lot of families want IV fluids. And the 3 patients that I started IVs on that were on hospice died within 24 hours because it's an overload on the heart.
Right.
It hastens them.
It does, and it makes them die. I mean, I've taken care of patients where you could hear them breathing from the nursing station, you cannot get it out. That is the most gut-wrenching, heartbreaking thing, is to watch people lay there and basically drown to death. I mean, that's really what they're doing.
Studies show, though, that the death rattle, you're not suffering. They are not suffering.
Death rattle is different than having fluid in your lungs. Death rattle is when you have that little bit of basically snot, sputum in the back of your throat. And you know, we've all been sick, and that's all that is. It's just stuff. They don't have the muscle strength to cough it up. They don't have the muscle strength to swallow it down. So that it sticks right there in front of the flap and just rattles every time they breathe. Studies have shown that patients that are a little dehydrated die more peacefully because their lungs are drier. Like I said, another myth is that they put everybody on morphine and they die. Well, I'm here to tell you, I've taken care of people that have been on 1,000 milligrams, literally, a day of IV morphine that were walking and talking. You know, we come from a very different place, and when I first came from the med-surg floor to hospice, like I said, we used to deliver our own medicines, and they gave me a 1,000 milligram bag of morphine to take to a family. You know, I'd come from where you gave a milligram, you went and watched them every 5, you know, make sure they're still breathing. And she said, yeah, just give it to them. You just want me to give this to them? They really do build up a tolerance. And it really does help people breathe so much easier. It relaxes the lining of the lungs. It helps slow their respiratory rate when they're breathing 30 sometimes a minute. That's a good thing. So anyway, a couple other things. You know, we don't starve them. If they want donuts and they're diabetic, they can have donuts. You know, they don't need to eat 13 donuts, but they can eat a donut or 2. You know, at that point, it's all about comfort. It's all about quality of life and living the best you can live it. You know, people do have terminal agitation sometimes, where they start feeling like they're just, you know, everything just starts misfiring in there. So that is one reason that they are sedated sometimes. And it's a very uncomfortable way for somebody to live, having that terminal agitation and just, you know, be trying to crawl out of the bed and everything. They will start running hot, which is normal. You know, people worry about temperature, check their temperature, we need to give them something. But it's just the dehydration, it's the changes in the body and everything, that's normal. All right. Do y'all have any questions for me?
I think one of the, I mean, you know, since we're not usually involved in the last we're at the end where they need to move into hospice
Right.
or start thinking about it or present it to the family. I find that is like the most uncomfortable conversation to have.
It is, and it can be, and you know, I still do it. When I go do admissions, I talk to people about, if I see that they're really hospice appropriate, I tell them, you know, I hope for you, if your goal is to get well, that is what happens. But if it doesn't, if things don't go that way, you know, there are other options, and I would just like to tell you about them, and just explain to them some about hospice. Also, you know, I think that advanced directive in the book, you know, I explain to everybody, even if, you know, I tell their family members, even if you're 40, do an advanced directive. And as things change, you know, I've had several people say, well, I have one, but it was years ago we did it. And I said, well, then you might want to readdress it because, you know, you're not the same as you were then. And, you know, things are changing. And so I think that you just have to, you know, we need to think of end of life as a part of life and not, we're just, you know, the hospice is about death. It's about death. It's really, truly living each day the very best you can live it. And then when that time comes, helping people be as comfortable and peaceful and die with dignity and respect.
Lisa, how is it, those evaluation scales that you mentioned, are they a little bit subjective? And would that be why some hospices accept the patient after some other hospice did not?
Right. Well, I will tell you that every hospice can choose to accept who they want to. Just like in every areas of life, there are scrupulous hospices and there are unscrupulous hospices. When I was the unit manager where I came from, I stuck with the guidelines. You know, I was not going to lose my license, you know, by committing Medicare fraud, and I wasn't going to get our company in trouble by doing that. And we had patients that we had to discharge off hospice, and other hospices will pick them up. You know, they will, and there are hospices that are being fined. I think one in Alabama a couple years ago got the biggest fine ever, and it was multiple millions of dollars. Because of Medicare fraud. And it's happening more and more that they're, you know, as Medicare's tightening down and looking at things more, they are finding that, you know, they're looking at those different things. So that's why some hospices will accept people and some won't. Sometimes, you know, there are hospices that won't accept somebody because maybe they didn't want to have to deal with something the person's going through. If you know that's that is something that people, like palliative radiation, most every hospice will accept a patient on palliative radiation. So if you have a hospice that, you know, says they won't accept them on palliative radiation and you really feel like that person needs hospice, there are hospices that will accept them, and it is within their right to, they are the ones that's paying for that palliative care, just so you know. So if you do talk to a hospice, that you see that they're meeting the criteria, the family really wants it, but you know, the hospice you contact does not want to admit them at the time, you know, I feel like it's our responsibility as an advocate for the patient to get them the care they need. So. Okay.